Hi, my name is Phil Scheinberg from Sao Paulo, Brazil, and I'd like to thank the organizers for the invitation to talk at another IBMFS. I really hoped I was there in person. I didn't go, not because of COVID, but because of other reasons, but I'll make sure I'll be there the next time. Thank you very much for Major George and other organizers that I know there are a lot of people involved in a meeting like this. Um, and I'll talk to you about in the next 20, 25 minutes about the role of TPO agonists in aplastic anemia. Obviously, I'm sure you're aware that this is a class of drug that has had activity in this setting, and I'm going to describe to you a little bit in more detail this activity here. So my disclosures. Um, and this is an empty bone marrow. This is a plastic anemia. And just by looking at the bone marrow, you can't tell exactly what's behind the etiology here. But this is in contrast to a more cellular looking healthy marrow. This is from the same patient. At the right, at the time of diagnosis, and the left, 6 months after immunosuppressive therapy. So we know that marrow function can improve and can recover. We'll be talking about immune-mediated aplastic anemia. I'm not going to be talking about Fanconi dyskeratosis, other hereditary forms or drug-induced or infection-induced. But we're going to be talking about primary immune-mediated destruction of hematopoietic progenitor cells that occur by expansion of cytotoxic CD8 T cells, lack of regulation by decreasing Tregs and Bregs, increasing pro-inflammatory Th1 and Th17 gamma TNF alpha cytokines that lead to the recognition of and destruction of HSCs, which leads to pancytopenia, hypocellular marrow, and if untreated, obviously serious complications of infections, transfusion related, and death eventually. Um, so pancytopenia and a hypocellular marrow is a hallmark of this disease, and it is a diagnosis of exclusion. And age is still used as the sole discriminator of how you're going to manage these patients. If you're younger and have an HLA matched sibling donor, transplant should be offered. If you're older or don't have an HLA matched sibling donor, then IST or a non-transplant treatment modality is preferred, given the risks associated with transplant in patients over the age of 40. Horse ATG cyclosporin has been studied for decades in many parts of the world, and the response rate is about 60 to 70%. So we do have a third of patients here who do not respond to IST. And there's a very powerful correlation between response to IST and survival. Very potent. So if you respond to IST, you have a very high likelihood of being alive. Many things were done to try to address this one-third of patients here who don't respond and try to increase the response rate. And nothing seems to have actually make any difference, like adding a third drug like mycophenolate or rapamycin, or keeping cyclosporin for longer, or adding GCSF. Didn't really do much beyond what horse ATG cyclosporin does. And surprisingly, adding more lymphocytotoxic therapy like alemtuzumab or rabbit ATG, which causes a much more profound lymphocyte and prolonged lymphocyte depletion, really didn't do much better than horse ATG. Horse ATG, the standard therapy, 60 to 70%, uh, is what we have expected and is the results of what was found in this trial. The problem is that the results with the other agents did very poorly, like rabbit ATG, alemtuzumab. And cyclophosphamide, although it can be active in this disease, is pretty toxic um, because of the profound neutropenia that it causes. I mean, we did 2 trials, lots of deaths from fungal infections and mucormycosis, even with voriconazole prophylaxis. So compiling all studies that actually compared horse to rabbit ATG, all prospective studies actually show that horse was better. Many of the retrospective studies show the same thing. And 2 meta-analyses with almost over 1,400 patients actually show that the horse formulation is superior to rabbit formulation across several studies, including meta-analyses. So, quercetin cyclosporin is actually a modest immunosuppressant. It's not a very powerful one, so you may not need too much of an intense immunosuppression in this disease. So the question is, what do you need and how can you improve response rates? And the answer kind of came through a different route, not through the immunosuppression route, but through doing something that people have tried to do for a long time, which is stimulate the bone marrow. People have done interleukin, stem cell factor, high dose GCSF, EPO combinations, and uh, didn't seem to improve outcomes in terms of stimulating the bone marrow. Because remember, when you have an autoimmune insult that you're attacking the bone marrow, you relieve the bone marrow from that insult, and then you give it the space to and time to breathe and to eventually recover. It's an autologous recovery. But if you have such a destruction of the bone marrow compartment, you really, even after you take away that insult, the bone marrow really can't recover. So imagine you are in a situation where you're having profound destruction of progenitor cells. You probably don't respond to IST in the sense of not that you don't control the immune insult, you probably just can't have enough cells to regenerate. Um, which contrasts, for example, with those who have more of a reserve. And if you do get rid of the autoimmune insult, you may actually have a higher chance of responding. This is theoretical. This is not data. So kids do better with IST. Is that because they have more stem cells? That's hypothetical. Are there surrogates that can actually give you some sense of how much reserve or how much stem cells left? You can't quantify that in real time in humans. Um, Correlate with outcomes in terms of having a more regenerative bone marrow uh, to start with. So this is a hypothesis. And in 2008, there were two TPO agonists that were approved for a different disease called ITP, which you're obviously very well aware of. And we thought of trying something different like this, although we were very skeptical that this could actually work in plastic anemia for reasons that I'm going to tell you in the next two to three slides. It was approved for ITP and worked for ITP, both eltrombopag and romiflostim. And we started in 2009, we wrote a protocol for second line refractory patients with eltrombopag at the time who had not responded or had an insufficient response to IST. And to our surprise, 40 to 50% of patients actually responded to this oral outpatient regimen. And this was in second line. It got approval in the United States and Europe in second line, and later it was brought to front line, and the results were actually very striking. And it got approval in the United States in front line in 2018 in combination with IST. And there's been several countries now in which the combination of triple therapy, which we call it ATG cyclosporin ultramopag, is approved, including where I live in Brazil, and in many countries in Latin America, it is approved in frontline. So, what is the data here, and why were we skeptical? Well, why were we? What the rationale? Well, TPO is expressed in stem cells. You can see that MCSF, GCSF, EPO are not expressed on stem cells, but TPO is thrombopoietin. So there is a possibility that you might stimulate a progenitor cell here, or a very early progenitor cell. And we know that people who work with stem cell biology who wants to stimulate stem cells in vivo, they use TPO with FLT3 ligand and other cytokines to try to stimulate that population in the laboratory. And mouse models where you don't have thrombopoietin active have megakaryocytes that are low, platelet counts that are low, but you do have stem cell numbers also that are low, indicating that thrombopoietin is an important modulator of stem cell population in animal model and in humans, because there's a disease called amegakaryocytic thrombocytopenia, which is characterized by a MPL loss of function mutation. And these children actually develop multi-lineage marrow failure. They start with low platelets, low megas, but they eventually develop pancytopenia. So indicating that when thrombopoietin is not active, is not there, you do have a problem with the stem cell population. The problem is that the endogenous thrombopoietin level in patients with aplastic anemia is off the roof. It's sky high, over 1,000. And we did these studies consistently before we moved on to these studies, and we were very skeptical that giving more stimulation through this pathway would actually do anything. It's like seeing an MDS patient with anemia. You check their EPO level in their blood, and it's 3,000. It's not likely just by giving erythropoietin subcutaneous that you're going to make that anemia better. So we were very discouraged, but we did the study anyways because we didn't have anything better to do and we had no better ideas. And we started out with a lower dose, and we have the 150. These are Western doses, not Southeast Asian doses, um, which are half. So 150 milligrams was the cap where we stopped, not because of toxicity. We started with 25, 50, 75, 100, 125. We started at 50, 75, 100, 125, 150. So we went up by 25 milligrams every 2 weeks, and we stopped at 150. There was a response criteria that was established. Primary endpoint at 3 months, 3 to 4 months. And there was a ramp up. So there's a ramp up because we had never given these higher doses before. Nobody actually had given these higher doses before, not even the company 10, 12 years ago. So the pilot study was actually positive. 40% of patients responded. It was followed by more patients, 43 in total. And we saw multi-lineage responses, bilineage and even trilineage responses, which led to transfusion independence. And it was a very well tolerated outpatient regimen. It was single agent, was not in combination with IST. Headaches, myalgia, LFT abnormality seen in 10 to 15% of patients. In the most cases, we just monitored. Okay, very infrequently we had to stop because of the LFTs went up 6 times upper limit of normal. But we were able to actually stop. LFTs went down and we challenged the patient. It was very, very, very unusual to have to stop the drug entirely because of LFT abnormalities. But you have to monitor this weekly, especially in the first month. But it was, 40%. And these patients actually tended to do well. What was interesting is that we were able to stop eltrombopag in some of these patients, especially if they had robust response, meaning that they had a platelet count greater than 50, hemoglobin greater than 10, neutrophil count greater than 1,000. By accident, and we can actually detail this in the Q&A, we found out that there were 2 patients who actually had to stop the drug, and their counts just kept going up and up and up. And we thought that probably patients didn't need to be on this drug forever. And that turned out to be true. These are some of the counts going up. So you can see that these are not just minimal increases in counts. These are significant. Look at platelets going from 10 to 30, 40, 50,000. So patients go off transfusions. Same with hemoglobin. This is which really caught our attention, multi-lineage responses. So you get a sense that you're stimulating a very early progenitor cell, especially at the higher doses. We saw responses at 125, 150. We infrequently saw responses at the lower doses. It doesn't mean that they cannot happen. It's that it was at the higher doses that we saw responses. And that's also true for some studies in MDS who have tested both romipilsin and eltrombopag. It's really at the higher doses that you see responses in terms of immunologic improvement. So it seems that in marrow failure syndromes, you need a higher dose probably to get that stem cell progenitor cell. And the cellularity in this 2012 paper actually shows that there was an increase in cellularity after eltrombopag pre and post, giving you a sense that you're repopulating the bone marrow. And the drug is doing what we thought it was going to do. Clonal cytogenic abnormality was something we were very worried. We were worried with clone evolution, fibrosis, and thrombosis. Because remember, this is 10, 12 years ago, and we were using higher doses. So we did bone marrows at baseline at 3 months, 6 months, and 12 months. These are 4 bone marrow biopsies in a year. That's a lot. But we were worried. It's research. You have to make sure that you're not doing anything harmful or unintended consequences. So that's part of what we do in clinical trials. So we did see cytogenic abnormalities, which we saw in aplastic anemia normally in refractory patients, especially in patients who were treated with IST without ultralimpide. And these were the abnormalities that we saw with ultralimpide, monosomy 7, trisomy 8, deletion 13q. So that, the pattern was very similar. Um, and we know that 10 to 15% of patients can evolve to clonal evolution. Now, remember that for all the NIH trials, any cytogenetic abnormality was defined as a clonal evolution. Any. And we now know that there are cytogenetic abnormalities that are high risk and those that are of low risk. But the definition of any cytogenetic abnormality being counted as clonal evolution is very conservative, actually, and severe. But we thought it was probably a more uh, conservative way of determining this. What about if you don't do a ramp up? Instead of doing 50, 75, 150, you do 150 from day one and do 6 months instead of 4 months. So this is what this other trial asked. 40 more patients. And we learned a few things. 20 patients responded out of 40, so that's 50%. Not too much different from 40. So, are you getting much benefit? From the incidence of response, no, but from the quality of response, yes. So you get more robust responses when you give 150 on day one and you give the drug for 6 months. And that is interesting because 19 out of the 20 responders had a robust response. And that's important because remember, I told you, if you have a robust response, you actually have a higher likelihood of being able to stop eltrombopag. And that's obviously very exciting. Obviously it's very exciting to give a drug and have a patient respond to it, but it's also very interesting to know and to learn that this patient doesn't need to be on this therapy forever, especially if you're 19, 22, or a younger patient, right? And most of these patients are able to tolerate discontinuation. Most do not have to go back on eltrombopag after stopping. And it's a quick taper. You cut the dose by 50%, give 4 to 8 weeks. If the counts don't tank, they can fluctuate. That's okay. But if they don't tank, you can actually stop the drug after 8 weeks and see if the patient tolerates discontinuation. Sometimes the platelet can go from 190 to 130, 120. That's expected. You shouldn't restart eltrombopag just for that reason. But if they drop to 20, obviously that's a big difference. And all patients respond again to eltrombopag if you have to restart the drug. So giving 150 from day one and giving it for 6 months seems to be the more optimal way of giving this therapy in second line in patients refractory to IST. And this is the regimen that was incorporated in the frontline trials. All right. So what is the drug doing? Well, we think it's stimulating stem cells, bone marrow. We know that it's an iron chelator. It breaks down ferritin goes lower in these patients. But we also know from the ITP studies, not much in the plastic anemia studies, but we know in ITP studies that the eltrombopag has an immunomodulatory effect by decreasing pro-inflammatory cytokines and increasing regulatory immunomodulatory cells. So how much is this contributing to the response? We don't know. Probably the combination is what's doing it. So it's probably safe to say that we're actually shifting this curve to the right and increasing the number of stem cell reservoir numbers and increasing the probability of recovery after we do control the immune attack. This is a paper we published last year, and this includes all the trials that used mainly eltrombopag. Romi has been far less studied. But if you add and divide all the eltrombopag trials here in this table, it'll give you 50%. So 50% seems to be a safe number. This is a lot of real world data, so very consistent. And this led to the rationale to give frontline therapy with ATG horse, cyclosporin, eltrombopag, which was done at the NIH, started the trial over 10 years ago. Obviously, the RACE trial, which was published in January of this year, which used cohort 2 of the American trial. So if you look at RACE, they start eltrombopag on day 14 and give it for 3 months. If they do have a complete response, you can stop eltrombopag. If you don't, you give eltrombopag up to 6 months. That's RACE. All right. And the reason is because when the European trial, which we were kind of involved, was being developed back in 2014, 2015, this study was in the second cohort. And that was used as the basis for RACE. The first cohort was actually the same thing, starting on day 14 and giving it for 6 months. We tried to break the drug exposure. We saw some response that were lost here. So we increased back to 6 months in cohort three, and we brought the Eltron back to day one because when we started that trial 10, 12 years ago, we weren't sure about combining Eltron with cyclosporin or even ATG. So that concern actually decreased, and that's why on cohort three, and there's about 30 patients in each. We combined all drugs on day one, giving Ultravag at 150, again, lesser doses, all three drugs simultaneously. And this has actually turned out to be the best response, actually. 90%, 50% complete. This was a single arm, non-randomized trial. We did see responses, obviously, that were interesting in the first and second cohorts, but cohort three was the one that really called the attention, especially in regard to complete responses. The primary endpoint for this study was to have a complete response by 6 months, over 30%. So it was a positive study because the response here was 44% complete if you aggregate these numbers. And that compared very favorable to a 10% a huge historical and very solid historical database of patients, all treated in a clinical trial at the NIH, using the same inclusion criteria, same response criteria, same regimen, same everything. So it's a very unique historical cohort, actually, because they were all treated prospectively in a clinical trial. So this really gave you a sense that the combination of eltrombopag with IST was giving you an additive effect. And obviously, I mentioned that response correlated powerfully to survival. So by the time of this publication, median follow-up of 18 months, survival was excellent, as you would expect. We did see cytogenic abnormalities, as we do see without eltrombopag, and these were basically in two groups, monosomy 7 related or chromosome 7 related, which were we considered high risk because these correlated with no response, dysplasia, and usually evolution to high risk MDS. So obviously these counted as clonal evolution. But there were patients who had non-chromosome 7 uh, changes, deletion 13q, trisomy 6, no dysplasia, great counts. Sometimes it was transient, and these counted as clonal evolution as well. So again, very conservative, but these aren't their significance. You shouldn't do anything with these cytogenic abnormalities because they don't seem to be dominant or causing a problem here for this patient. Um, so there are high risk and low risk abnormalities that have been identified. These data were updated actually to include 176 patients treated with ACE, ATG cyclosporine eltrombopag, and overall 14%, but that includes high risk, low risk, et cetera, et cetera. If you look only at high risk, that number is actually less than half of 14%, it's 6%. So out of 100 patients with ACE, only 6%, at least so far, with a median follow-up of 4 years now, actually developed high-risk clone cytogenic abnormalities, and that didn't seem to differ too much from historical controls. So we don't get a sense so far that EPAG is increasing their evolution to high-risk clonal evolution. Up 4 years median follow-up, 90% still survival, especially if you responded to ACE. This is close to 95%, even more favorable. So most patients actually respond and most patients survive. And eltrombopag has been added to the algorithms with IST, especially in adults. The results in children are a little less definitive. There seems to be a benefit, but not as much as in the adults. For sure, the adults benefit tremendously from adding eltrombopag to IST, and this also has been incorporated to more recent algorithms. IST plus eltrombopag frontline if you're not a candidate for transplant. Just to conclude, race trial, New England Journal, January 6th, recent data, head-to-head, 1-to-1, ATG cyclosporin horse versus ATG cyclosporin eltrombopag, so standard versus ACE, or A versus B. B is the experimental arm. Hematologic CR at 3 months primary endpoint, which was achieved in this more than a 3 times increase in the CR rate compares to arm A and B. A is standard, not 3 times, I'm sorry, doubling, more than double. CR, but overall response rates as well. Uh, so RMB was better in terms of overall incomplete at 3 and 6 months, and that's ACE. That's a 3 drug regimen. Response were quicker. Patients went off transfusions not only at a higher frequency but more quicker, and that's obviously very very important. Look at RMB in red compared to RMA. RMB is ACE, the triple therapy. Again, no mutational correlation between baseline and response to IST, and no preferential expansion of mutant clones that were identified at baseline in the eltrombopag arm. And this is a direct comparison, head to head, 1-to-1. So this is very, very important data to be published, and survival so far has not been different. There seems to be something going on here in terms of R&B being better, but follow-up is still short, so we have to monitor this, or the Europeans have to monitor this for a longer period of time and give us long-term data for cytogenetic abnormalities, relapse, and other long-term outcomes. So we thought this was practice changes. This was published in the journal, and we were happy to write the editorial for this trial. This is a state-of-the-art standard of care change. And horse ATG cyclosporin became standard in 1991 when it was compared to horse ATG alone in a New England Journal paper. So it took 30 years, 2021, for us to actually have a new standard. And just to finalize my talk, SOAR trial, no ATG. This was done because of all kinds of reasons. When it came to Brazil, access to horse ATG we didn't have. We still don't have readily access. Hospital beds, having to put these patients in the hospital, put in a catheter, ATG-related toxicities, all the things that come associated with that. So could you not give ATG and give eltrombopag cyclosporin alone? Again, 150 given for 6 months, along with cyclosporin. Primary endpoint was a response rate greater than 30 by 6 months. That was the primary endpoint. This was presented in abstract form only. Most patients were older than you see in the plastic publications. The median was 55. Over half had an ECOG of 1. More frail, fragile, couldn't go to transplant. Doctors didn't think ATG was appropriate. The overall response rate was 46%. This is intention to treat, okay? Because there were some patients that had to be taken off the study early just because of discrepancy between cytogenetics. So we'll put that in the final report. But if you're younger, you had a response rate that was close to 55% by 6 months. So it's an active combination, as you would expect without ATG. And it could be a very interesting option, especially in older patients. And just to conclude, these are the responders in the bottom, and these are non-responders on top. This is presented at ASH. It's interesting to say that almost 50% of the non-responders actually met transfusion independence criteria, meaning that their transfusion actually spaced out, or they were able to be off transfusions despite the fact that they still did not meet criteria for response. So if somebody is not eligible for ATG or transplant, or is in a place where ATG is not available, or there's a horse ATG, so there are scenarios where you can envision that this is a combination that might be applied. There's no regulatory approval for this combination, but this is research, this is clinical trials. This is presented in 2 big meetings right now. Eltrombopag cyclosporin don't have overlapping toxicities. As you know, cyclosporin has kidney toxicity. The toxicity with eltrombopag, for the most part, is hepatic in 10 to 15% of patients. And in East Asian patients, the dose has to be cut in half due to pharmacokinetic adjustments. So, summarized, TPOs, basically mainly on eltrombopag, anaplastic anemia, second line, front line, where we are today, gave you very recent data, very recent updates. Thank you very much for this invitation for IBMFS. For the organizers, it's really a pleasure to be able to address an audience of physicians in India. I've been there several times, really like a lot the country, and I'll be available and make myself available for a Q&A. Here's my email for any questions. If you would ask, discuss cases, I really enjoy discussing patients, and I learn a lot from that. So thank you very much once again. and we'll be available for the Q&A.